Hello and welcome to a presentation on the success and cost effectiveness of minimally invasive glaucoma surgery. I'm Khurana, a glaucoma consultant with Shankar Nethralaya, India. Minimally invasive glaucoma surgeries are a diverse group of relatively new procedures that lower intraocular pressure with limited or no disruption to the conjunctiva or sclera, typically in eyes with mild to moderate primary open-angle glaucoma. They have a modest IOP lowering, are usually combined with cataract surgery, often in the early stages of glaucoma. They pose fewer risks than conventional filtering surgery. MIGS can be classified under subheadings based on whether they increase the aqueous outflow by bypassing or dilating or disrupting the trabecular meshwork, increasing the suprachoroidal outflow, or by forming a small subconjunctival bleb, also known as minimally invasive bleb surgeries or MIBS, or decreasing the aqueous production. Considering MIGS promises many perceived benefits over conventional filtering surgery, let's look at the success of each procedure. The goal of MIGS is different from glaucoma filtering surgeries, where the goal is IOP lowering only. In the presence of well-controlled glaucoma and cataract, the goal is to reduce the medication burden to improve the quality of life. IOP lowering is an additional benefit. Thus, the efficacy outcomes used in most studies are IOP reduction, where a medication washout was performed for both pre- and post-operative assessments, and IOP reduction with concurrent medication reduction, where no medication washout was done. The American Academy of Ophthalmology performed a technology assessment of trabecular procedures which were combined with cataract surgery versus cataract surgery alone. 20 studies met the inclusion criteria. 10 RCTs were selected. It is important to note that they found that all studies were subject to potential industry sponsorship bias. Pivotal trials for iStent first generation, iStent inject, and Hydrus were included. They found that cataract surgery alone resulted in 21 to 28% IOP reduction. That is a mean IOP reduction of about 5.4 to 7.6 mm mercury. An additional IOP reduction of 3.8%, that is 1.6 mm mercury over cataract surgery, occurred with iStent inject, and about 8.7 to 8.9%, that is 2 mm mercury with Hydrus, over 2 years. At least 20% IOP reduction without medications was seen in 53% eyes with iStent first generation, 75.8% in iStent inject, and about 77 to 80% with Hydrus. The IOP lowering was significantly more than cataract surgery alone. For the iStent studies without medication washout, IOP reduction was 8.1% versus 0.6%, and medication reduction was 81% versus 73% as compared to phacoemulsification alone. At 5 years, although IOP was similar among the two groups, but significantly more eyes in the Hydrus group remained medication-free at 5 years than the cataract surgery alone group. Additionally, a post-hoc analysis showed that cataract surgery along with Hydrus had a significant effect on visual field preservation as compared to cataract surgery alone. In a case series, 2 iStent Ws with phacoemulsification had 19% IOP and 22% medication reduction at 6 months. While all these trials looked at trabecular bypass procedures combined with cataract surgery, what about standalone procedures? The COMPARE trial looked at standalone procedures, that is Hydrus implantation versus 2 first-generation iStents without cataract surgery. Patients with more advanced glaucoma as compared to the previous trials were included. They found that IOP lowering was significantly more in the Hydrus arm. Significantly more eyes had IOP reduction of 20 or more percent. However, 2-person mass tonometry method was not used, no medication washout was done at the end of the study, and there were no clear guidelines for restarting medication. Kahuk dual blade is an ab interno trabeculectomy MIGS device that excises diseased trabecular meshwork. This meta-analysis studied the efficacy of phacoemulsification with and without Kahuk dual blade goniotomy in individuals with open-angle glaucoma or ocular hypertension and cataract. They found that combined KDB goniotomy with phacoemulsification led to about 22.7% IOP reduction from baseline and also mean medication reduction significantly more than cataract surgery. As compared to single iStent first generation implantation along with cataract surgery, KDB with cataract surgery in a randomized controlled trial showed no significant difference in IOP lowering. However, the proportion of eyes at 12 months with IOP reduction more than 20% from baseline or medication reduction more than one medication from baseline was significantly higher in the KDB group. Comparing phacoemulsification with KDB versus phacoemulsification and 2 iStent injects, both had similar IOP lowering at 2 years. 32% in iStent group had more than or equal to one medication reduction as compared to 53% in KDB phaco group. At 72 months, a 46.2% success rate was observed by Vasu et al. With KDB. Eyes with standalone KDB had a 11 to 36% IOP reduction and 15 to 92% medication reduction at 4 to 18 months in various studies. The reduction was more in eyes with a baseline IOP more than 18 mm of mercury. There are case reports of short-term IOP reduction in eyes with primary angle closure glaucoma and some diverse secondary glaucoma. A 1-year success rate of 87.5% has been reported with bent ab interno needle goniectomy. With microhook trabeculectomy, a success rate of 74.2% has been reported. Trabectome has a success rate ranging from 54 to 88% in various studies. This meta-analysis of angle-based MIGS in normal tension glaucoma reported an IOP reduction of about 2.5 mm mercury at 36 months with a medication reduction of 0.87. Devices are injected into the suprachoroidal space ab interno for aqueous drainage via this route, leaving the conjunctiva untouched for future surgeries. Although IOP reduction was significantly greater with CyPass combined with phacoemulsification versus phacoemulsification alone in the COMPASS randomized controlled trial, device was recalled off the market due to a higher rate of endothelial cell loss as compared to phacoemulsification alone after 5 years of follow-up in the COMPASS XT trial, highlighting the importance of long-term follow-up in these devices. Meta-analysis of non-randomized trials using Miniject in POAG as standalone showed a 39% IOP reduction, with 89% having IOP reduction more than 20% and 37.9% being medication-free at 2 years. In GAT or gonioscopy-assisted transluminal trabeculectomy, the trabecular meshwork is circumferentially cut off with a proline suture or a microcatheter to allow the aqueous humor to pass through the collector channels and the episcleral veins through the cleaved trabecular meshwork. Case series have reported a mean IOP reduction from 33% to 65% at 12 months and a success rate ranging from 63 to 89% at 12 to 24 months respectively, with failure rates ranging from 3.1 to 9%. Higher failure rates, 18 to 40%, are seen in eyes with previous glaucoma filtering surgery or with more advanced glaucoma. This is because in advanced glaucoma, the collector channels and intrascleral plexuses are sclerotic. A 4-year follow-up study reported a cumulative failure rate of 53.9%. Romeo, a retrospective observational study, looked at the outcomes of canaloplasty followed by trabeculectomy by Omni surgical system. 75% patients had either more than or equal to 20% IOP reduction or an IOP between 6 to 18 mm of mercury and no increase in medication or secondary surgeries at 2 years. Eyes with baseline IOP less than 18 mm of mercury did not have a significant IOP reduction. Gemini study prospectively looked at the 36 months outcomes with Omni and found 74% to be medication-free with a mean IOP of 16.3 mm mercury at 36 months. A quick look at the subconjunctival devices also, Zen and PRESERFLO. Now these have been compared to trabeculectomy. At 3 years, 35.3% IOP reduction was noted with a mean IOP of 14 mm of mercury with PRESERFLO. Postoperative interventions were also required. Other case series have also found IOP lowering to be to the mid-teens. A non-inferiority RCT of Zen 45 versus trabeculectomy with mitomycin C found Zen non-inferior to trabeculectomy. Although trabeculectomy has a significantly better IOP lowering, the Zen was non-inferior to trab with the additional benefit of less hypotony, fewer postoperative interventions, better visual recovery, and fewer adverse events. The Zen 63 in a case series showed a 1-year success rate of 68.8% in Caucasian eyes with mean IOP of 14.3 mm of mercury and a significant reduction in the medication number. The microshunt is a device implanted using an ab interno approach. In a non-inferiority trial, the 2-year success rate was higher in trabeculectomy. A network meta-analysis suggested that some MIGS procedures can afford greater drop-free disease control than cataract surgery alone, Hydra slightly better than iStent, although the effect size was small. Considering the success and efficacy, let us also look at the cost effectiveness of these procedures as it helps in resource allocation and clinical decision making. In this study, the authors looked at the cost of different glaucoma interventions per millimeter mercury intraocular pressure reduction in dollars at 1 year postoperatively. Effective cost of MIGS ranged from more than $3,000 to $7,000, lowest being trabectome. However, cost effectiveness does not involve only IOP reduction. Additionally, low-cost interventions like suture GAT and bent ab interno needle goniectomy are also available. These can be studied by performing a cost-utility analysis using Markov models and efficacy safety data from published pivotal or randomized controlled trials, as was done by the authors here for trabecular meshwork stents combined with phacoemulsification. They looked at total costs, QALYs or quality adjusted life years, and incremental cost effectiveness ratios. Using a Markov model, glaucoma progression through 4 glaucoma states and death was simulated over 35 years. Glaucoma cohorts with cataract entered the model and received cataract surgery with or without device implantation. Incremental costs per quality adjusted life years or QALYs gained were evaluated at a QALY threshold of $50,000. So I'll take a minute to explain these terms. Quality adjusted life year or QALY is a measure of value of health outcomes which combines the length of life and quality of life. So 1 year of life lived in perfect health is worth a QALY of 1, that is 1 year into 1 utility. 1 year of life lived in a situation with utility 0.5 is worth 0.5 QALYs. ICER is the difference in the cost between the two possible interventions, the standard and the new, divided by the difference in their effect or the QALYs. And depending on where this ratio falls, it may or may not be cost effective. In case it is below the slanting line, it will be cost effective. At the end of 35 years, implanting a trabecular bypass device along with cataract surgery was found to be more cost effective at a conservative QALY threshold of $50,000 per QALY gained as compared to medications or cataract surgery. The Hydrus arm was slightly less expensive and more effective than the iStent inject arm due to the difference in efficacy reported in the pivotal trials. Studies have been performed across the world with different healthcare systems, and most have found MIGS to be within the willingness to pay limits for each QALY gained. The Canadian Health Technology Assessment used a similar model but for a period of 15 years, and they found that there was insufficient evidence to make specific recommendations to the optimal use and funding of MIGS. The European Glaucoma Society argued that the cost effectiveness of MIGS was unclear due to the limited availability of evidence on clinical effectiveness and efficacy. Looking at MIBS also, a willingness to pay threshold of $50,000, the likelihood of microshunt being cost effective was only 6.4%. As compared with trabeculectomy, the pressor flow did show some cost savings. To summarize, with appropriate patient selection, MIGS causes a modest decrease in IOP over cataract surgery, along with decrease in medications. More robust evidence is required to see if there are less resurgeries and a lower rate of progression after MIGS. All MIGS procedures have not been compared directly to one another when combined with cataract surgery. The three most studied trabecular procedures appear to produce a modest and similar IOP reduction. Data on cost effectiveness is limited. Future steps include well-designed RCTs reporting effectiveness, health-related quality of life outcomes, visual field progression, and a longer follow-up. Thank you for your attention.